Hi, I'm Jerry Tan, and I want to thank the organizers for inviting me to speak at the ECMS Clinic Day. I'm going to share my slides. So I have entitled my talk, The Acne Journey. And this is in pursuit and treatment of pimples and its sequelae. My name is Jerry Tan. I'm a general dermatologist in Windsor, Ontario, and I've been practicing in this area since 1991. My conflict declarations with industry are here for you, including a number of companies that develop acne products as well as lasers for acne treatment. I own Windsor Clinical Research, and you'll see that we've developed some of the teaching materials in this presentation. And I also own the Healthy Image Center, which I'll show you some slides in which we do some of the procedural treatments for acne sequelae. I'm the co-developer of a number of intellectual properties for quality of life programs in hidradenitis suppurativa, the acne quality of life scale, and also in patient decision aids located at inform-decisions.org, one of which is actually on acne, and that's to help your patients understand their options and how to decide on whether appropriate treatments are reasonable for them to discuss further with you. So the agenda is very simple. One is starting by recognizing that there are at least two experts in the room. Number two is listing the elements of the personalized acne care pathway. And then number three is understanding the steps in guidance along this journey that I'll guide you through so that you can be a better guide as well. You are the expert, and you know that. That's why you trained for those umpteen number of years at medical school, in residency, and then in internship and further training as a practitioner. But there is also another expert in the room, and those are your patients, because patients are experts in their own lived experience with acne, how much it affects them at school, how much it affects them at work, how they are stigmatized by their condition. So, two of the questions I find extremely important to listen to the patient so that they are actually heard is number one, how does acne affect you? And number two is what are your goals with therapy? Oftentimes we presume we know what their goals are, but when you actually ask them, you might be able to align more effectively with what is truly bothering them and what they're really seeking help with. Their fear might not be so much the acne, it might be the pigmentation that they see develop on their siblings. It might be the scarring that they see on their parents. So it's important that we understand the context with which they are seeing you. They often come embarrassed, they're self-conscious, they're socially inhibited. They can be anxious and depressed because of their acne or because of something else. And many of these patients, when it's severe enough and it bothers them enough, they go through thoughts of self-harm and suicidal ideation. And stigmatization is an important issue, not just with acne, but also with acne scarring. The personalized care pathway I developed with colleagues in 2021. And this is in recognition of the fact that acne can be a chronic disease as defined by the CDC. It can last for a prolonged period of time, 1 year or greater for many patients. And even if it's a shorter term condition with active acne, the sequelae can be lifelong, like scarring. So we start off with self-management. Many patients self-manage. They look at social media, they look at magazines, they talk to their friends, family, pharmacists, and then they self-manage. And thankfully, many of them do extremely well. The ones that don't and enter into the medical pathway we then go into the typical medical paradigm, that is determining their patient profile, but most importantly, goal setting, as we've talked about before. And with goal setting, we then undertake treatment selection, initiation, and modification on a cyclical nature to make sure that we're achieving their goals or getting closer and closer to it. And as they meet their goals, we maintain treatment so that with prolonged improvement, we can eventually discontinue treatment. However, if the patient goals are not met, we return to review, reassess, and maybe reconfigure and re-strategize treatments. So if topical cream one is not helping adequately, why is it not helping enough? Are there other things in the way? Have we missed something that might be leading to more acne? Is this an athlete who takes a lot of whey protein? Is this a patient who uses a lot of comedogenic acne products that can trigger their acne, for example? So all of those might be relevant. And then we reselect treatment as well. But all along the way, look at sequelae. So this might be acne and the forest fire that's burning. These might be the effects of that fire, the burnt out forest, the stumps in the forest, the scars, the pigmentation, the burden, that is the quality of life adverse impact. And along well with all that, then we know that we need to have a little bit of guidance. So the guidance looks like this. Start off with what are you going to do in terms of treatment selection? So thankfully, there are a lot of useful guidelines to help you with appropriate selection of treatment. But beyond that is the why. Why are you selecting what you are selecting? And if you articulate that to patients, they'll understand how you've personalized what they have with what you're giving them. The next issue is going to be the how. The how for topicals is extremely nuanced and important. So I'll go through that in detail with you. And then the when. If you go to a workout class and your trainer says, go hard on your training bicycle, and he doesn't tell you when to stop, when do you expect that timeline? When do you expect to run out of steam? When do you expect that you can take a break? Well, all of these things, as you know, patients want to get better last month. Okay. But now that you're embarking on treatment with them, you want to make sure that they understand what the anticipated timelines are. And what if? What if there are problems? How do you mitigate some of these adverse events? For any of you who have ever prescribed topical retinoids or the fixed dose combinations containing BPO, benzoyl peroxide, and or retinoids, you know that these can elicit problems with skin intolerability. Then what else are you going to talk about? You're going to talk about skincare. Adjunctive skincare is so important because they can help to mitigate some of the adverse events on the one hand, and different products might help you advance improvement in acne on the other. So you've got to choose the right stuff depending on what you are prescribing and then measuring. How do you evaluate assessment? Okay, so let's do a deep dive into each of these in the next little while. What treatment? Well, thankfully, because of guidance documents, i.e., guidelines, most recently released by the American Academy of Dermatology, thankfully, a lot of the drugs available in the United States are available in Canada. And when I was involved with developing this, the nice part is that it was very clear that they wanted to do it in a way that was very clear and respectful of the credibility and quality of the data and the evidence, but also in terms of contextualization with regard to accessibility, cost, and equitability across the population. That's why in the methodology called the grade technique, the recommendations come out as the following: either strong recommendation for, conditional recommendation for, strong medic recommendation against, or conditional against. So what you see in this paradigm is that if the patient has acne, it's divided into mild, moderate to severe, and topicals The ones with the dark green dots are topical retinoids, benzoyl peroxide, topical antibiotics. Those are the ones that are strongly recommended along with their fixed dose combination products. The topicals that are conditionally recommended, clascoterone, salicylic acid, azelaic acid, those ones are conditionally recommended either because of concerns about cost, i.e., clascoterone, or because the data is not quite as rigorous as the ones that were considered to be strongly recommended. You'll see right below that the only physical modality is one where it was conditionally recommended against, and that's pneumatic broadband light added to adapalene. And that's because of increased risk of bruising and increased pain in patients who receive that combined modality. Now, how about systemics? Systemic antibiotics, the only one with a strong recommendation is doxycycline. Minocycline, sarecycline, those receive conditional minocycline because of concerns and considerations for greater risk of hepatotoxicity, drug-induced lupus, and sarecycline because of concerns about cost. Hormonal agents, you'll see combined oral contraceptives and spironolactone. The combined oral contraceptives, the class of oral contraceptives that has some of the best evidence are the class of agents that have progestins that are either low androgen potencies or have anti-androgen potencies. And those would be, the latter would be those that contain either cyproterone acetate that we have in Canada but not the US, or drospirenone. Why is spironolactone there? Well, spironolactone actually has now developed a folio of randomized control trials that supports its use, and that's why it comes in with a conditional recommendation. So remember, severity in many guidance documents is dependent on mild, moderate, severe, and that determination is observer-determined acne severity. That's how the FDA runs their trials, and that's how they get approval. So, for example, this is a set of virtualized faces that we developed a few years ago in Windsor Clinical Research, showing this young woman who doesn't exist, by the way. She's a composite of many different faces. And when we put her together, she is everyone and no one. Okay. But what we did then was we planted acne lesions on her. This is a patient who is now presenting with mild acne, moderate inflammatory, more on the severe end of moderate. Now this is severe, and then this is extremely severe. So the value there is you can see that using a scale like this, it allows you to understand the progression from none at all to extremely severe acne and back again. But there are other determinants of severity. Patients can be impacted because of psychosocial impact. Of course, it's not just the face that's affected, it's also the torso that can be affected. 50% of patients, when we did our research a few years ago in Canada, had truncal acne when they presented with facial acne. So if you have 100% of patients presenting to clinics with facial acne, about 50% of them have truncal acne. So it's really important for us to evaluate the trunk because your determination of appropriate therapy depends on severity of all of the affected areas, not just the face. And then, of course, there's scarring. Here you see a patient with multiple atrophic scars and then pigmentation. And some of these issues bother patients just as much as acne because they can be so long lasting. So with holistic severity, we look at the burden of acne, we look at the extent of acne, and then the acne sequelae we just talked about. And that type of assessment then leads you to establish what is bothering the patient the most over the past few months. And with that, you can start setting your treatment goals, and then you move on to skincare and appropriate lifestyle considerations, and then moving on to prescribed treatments and option schematics. And that's where it leads into the patient acne care pathway. So, how to use treatments? Well, it depends on what you're prescribing. So, let's start with topicals. I find it's extremely important to demonstrate application of topicals, show them how much to put into the palm of their hand so that if you demonstrate the use of the palm and a pea-sized amount in the palm, working it into both palms and then applying it on the forehead, one, two, three, pull up, reload, and distribute, and then one, two, three. That type of demonstration will stick because patients will remember your demonstration. What I don't try to do and try to indicate that they should avoid is applying it just on the spots. And I also get them to avoid applying the medications with their fingertips. The reason is if you make it longer in terms of time of application, many people will avoid doing it because they don't have the time. But if you show them this rapid use of a big paintbrush versus a small paintbrush, and you can show them how quickly it can be done in your office, that demonstration will take about 10 seconds. And if I was squirting stuff on, I'd be done by now. Okay. And of course, they can do the same thing on the chest, shoulders, and back if those areas are also involved. So we talked about field application because if you just treat the spots, you are putting your defense where they've already shot and scored on your net. And that's too little, too late. You want to play the zone defense so that you target and try to reduce any shots from any other spots that are coming in over the next 2, 3, 4 weeks, as long as you can to prevent the acne shots on your face, your net. So the volume of application, I think a pea-sized amount in your palm is fine. Frequency will depend on what you're prescribing. Remember, time of day or night, the most important thing here is if you're applying the first generation topical retinoid, they have to apply it at night. Why? Because tretinoin, first generation topical retinoid, is photo unstable. If you prescribe any of the other topical retinoids, that is adapalene, tazarotene, trifarotene, they are photostable. So they can be used also in the daytime if you wish versus the nighttime. But tretinoin has to be used at night because it's photo unstable. The other issue is benzoyl peroxide. If you get them to apply it at nighttime, remember that it may bleach their pillowcases. And if they apply it in the daytime and they have truncal acne, it might bleach their blouses and their shirts. So those should all be kind of little reminders of what to say depending on what you're prescribing. Systemic meds, of course, this is not a lecture on systemic meds, but here are a few highlights I wanted to review with you. With hormonals, importance of adherence, especially low dose oral contraceptives. And that's not simply because of acne. Actually, it's more because if they are taking it as a form of contraception, you want to make sure it continues to be as efficacious as possible. So they need to be adherent to it. Antibiotics, limit this to cyclins. Try to avoid cephalosporins. Try to avoid the aminopenicillins. Try to avoid anything else unless the patient has an allergy to cyclins. And the reason is we're trying to limit the risk of antibiotic resistance to all of these other antibiotics that are used for community acquired infections. Remember about taking it on an empty stomach, they should stay upright for 2 to 3 hours. That's to reduce the risk of esophageal regurgitation and water rash. The maximum duration of use to limit the development of antibiotic resistance is 2 to 3 months. So I want to be very conscious of the fact that in the past there was no guideline for maximum duration. Now there is, and we're trying to adhere to that to minimize the risk of increasing antibiotic resistance. Oral isotretinoin, this is a topic unto itself, but remember, if you prescribe it, please look at precautions, pregnancy prevention program, and laboratory testing. The relevance of laboratory testing is that we probably did too much blood testing in the past. Currently, what I do is baseline testing for ALT and lipids at baseline, that is before starting, and then within the first 1 to 2 months, I repeat it. And I don't do it again unless I'm escalating the dose or if there are some indicators of adverse events that suggest an internal issue. But otherwise, we don't have to do it every month that we used to do slavishly in the past. Low dose is extremely effective and has much lower risk of side effects compared to conventional dose. Now, low dose to me is about 10 milligrams per day. And that turns out to be almost zero point 0.1 milligram per kilogram per day. Previous conventional dose was 1 milligram per kilogram per day. That's 10 times higher the dose. That's why in the past, a lot of people had systemic um, side effects of arthralgias, hair loss, of course, a lot of cutaneous side effects of dry lips, dry skin. That's totally unnecessary because we can still get very nice efficacy, and there's nice randomized trials on that that suggest that low dose versus conventional dose, low dose is kinder and gentler. And when do you stop? When you don't see any more acne for a minimum of 1 to 2 months. The old adage of cumulative dosing should be expunged from the medical textbooks. And the reason is that we've moved on to understand that cumulative dosing was only because of limitations in use of the medication when that concept was developed in the 80s. It is no longer an issue because there is no restriction on how long we can use this medication for. And what happens is when you use this arbitrary metric is some patients will say, I failed the most important treatment that I was thinking of doing. I was worried about starting it. And then when I did it, my doctor stopped me when I reached, quote, maximum dose. I was still getting better, but I reached the number, so I had to stop. And I've heard that multiple times. It's completely unfair to that patient, and it's based on old information. So please treat that patient until there are no new acne lesions for at least 1 to 2 months. When to expect what? Well, the anticipated timelines look like this. Within the first 1 to 2 weeks, if you're in a retinoid of any type, whether it's oral or topical, that's going to be the peak of irritation and dryness. So you should know what to do and what to say to patients during that time to mitigate that during that first 1 to 2 weeks. 2 to 4 weeks, you're going to start seeing some improvement. 12 weeks is the duration of most randomized controlled trials. And the maximum efficacy of acne therapies, whether it's topicals, whether it's hormonal treatments, whether it's oral isotretinoin, is actually out at about 20 weeks. And I'll show you an example of this. There are very few randomized controlled trials on topicals going out to 6 months. We happen to do this in Windsor Clinical, and during that period of time, this is the standard embargo period for randomized controlled trials in acne. And you can see 31% of patients achieving clear, almost clear is excellent. And this is what we actually saw in the phase 3 clinical trials for this product when it was approved by the FDA. However, because this was a double duration, it was twice that duration, it went out to 24 weeks. What we saw was the extent of improvement achieving clear, almost clear, was double that at 12 weeks. So it's a really important lesson that if your topicals are working, keep going and they'll keep improving over time. What if you have concerns about irritation, risk of dryness? Of course, these are all retinoid, benzoyl peroxide, glycolic acid types adverse events, as well as oral retinoid adverse events. So we did a randomized trial a few years ago looking at every other night. So less frequent application, mandated moisturizer 3 hours per night compared to the standard overnight application. And my co-authors here were all Canadian because the sites, Windsor, Montreal, and the last two authors were from the funding company. We did this in the middle of winter to try to drive the potential for dryness. And what we found was the least problems with cutaneous intolerability. Here, the higher the score, the more the intolerability. And you can see very high scores for every night as well as as well as 3 hours per night application. Short contact and standard reach the same level of intolerability within the first week. However, when you used moisturizers and when you used every other night treatments, it was much less in terms of cutaneous intolerability. So it's a very clear signal that we can improve how we do things for patients on topical retinoids. And that's why I think the role of these skincare products, dermocosmetics, can help you mitigate adverse events. And if you choose ones for augmenting efficacy, for example, you will look at ingredients that contain glycolic acid, salicylic acid, topical retinols. Those can all augment efficacy. There are over-the-counter ones that contain benzoyl peroxide as well. But you have to get into this with a very clear-minded notion of, are you trying to use this skincare to mitigate problems? Or are you trying to use this skincare to augment and improve the acne? So if you have a heavy hitter on prescription, you're going to want to come down in mitigation. Okay, let's say you've got one of the new topical retinoids. It may or may not be a fixed dose combination. You want to mitigate adverse events. If you have a very gentle product that is extremely well tolerated and you're just wondering about how you can kick up the efficacy, then you want to come down this pathway in terms of cleansers that contain sal acid or benzoyl peroxide, perhaps leave-on serums that might contain some of those actives as well as niacinamide. So here are my practical tips for you. If you're using topical retinoids, either solo or in fixed dose combinations, number one, gentle cleanser, no acne actives, and these gentle cleansers should not be soap. Soaps have saponifiers that basically remove your natural moisturizing factors. Not a great idea. Start slow and then progressively escalate. Dinner to bedtime is very sensible because basically you apply the product, and if you're irritated at any point in time before you go to bed, rinse it off. And if you're not, rinse it off before you sleep and then apply moisturizer overnight. If you're concerned that this is a very sensitive patient, you can always dilute with moisturizer, for example, 3 parts moisturizer to 1 part medication for the first 2 weeks. And then you can progressively reduce the moisturizer if things are improving nicely. So how to evaluate progress? Typically, what we do is assess in the following way, more frequent follow-up. I ask patients about treatment satisfaction with this very simple question: how satisfied are you with your treatment? We use photos, but if you use photos, no more than once per week, and always ask them to put it into its own catalog so that not flipping through 2,000 photos to look for that one for you, and use an objective scale. What else? Well, scarring is the single most important acne sequela. So we do a lot of treatments for acne scarring. And the reason is people are so bothered. And this is an example of patient with the TCA, that is trichloroacetic acid, cross technique to treat the ice pick scars, the patient getting cannula subcision to reduce his rolling scars. And you can see there can be very nice improvement, but it's never perfect. And another patient with combination treatments as well, nice improvement, but still some small residual scars. And certainly when we treat, we also use many of our lasers. Vascular lasers can be extremely helpful for the macular erythema, and these can be in patients who are under prescription therapy at the same time. Microneedling, lots of treatment with microneedling because they're so generally effective in atrophic scars. And then lastly is fractional laser resurfacing. And this is a nice way to finish off the surface to give it a smoother appearance. And whether patients are on medications or not, we can certainly continue that treatment and initiate it at that time. Lots of issues with scar correction procedures due to cost, pain, adverse events. It's always incomplete, and there's a recovery phase to it all. And oftentimes we'd have to do it multiple times. So in summary, acne patients, they're vulnerable, they're frustrated. You're the expert guide on their acne journey, but patients are also experts. So consider using this guideline checklist for the patient journey. We do take acne referrals. My partner, Dr. Majmudar, and I, here we have the fax for both of us. If you need to email me, I'm here at officedrtan@gmail.com. Acne scar repair is non-OHIP insurable. So there is a contact there for the Healthy Image Center along with the telephone number. And with that, this is the end of our journey. I want to thank you, and I hope that was of help in guiding you and your patients through their journey. Thank you.